Thank you, everybody, for being here today. I'm glad to see everybody in New Orleans. I'm very glad to see cities coming up and seeing everybody meeting back again in person, something I dearly missed over the past 8 or 9 months. I'm going to be talking today about a couple of things, and I'm going to start with the study for peripheral diabetic neuropathy, painful diabetic neuropathy that was done with high-frequency stimulation. So we happen to be one of the sites for that study. It's a randomized control study that was looking at treatment of painful diabetic neuropathy, comparing two arms, a medical management arm compared to medical management plus spinal cord stimulation utilizing 10K. The results of this study at 6 months results was published to JAMA Neurology, and these are the results I'm going to be discussing today. Hopefully in future meetings we're going to be seeing the 12 months results of this study, and also maybe seeing a lot of sub-studies that comes out from that study. Study design was pretty simple, really managed control group. Whoever was diagnosed with painful diabetic neuropathy. We had a very similar demographic group of controlled medical management in a group that would have received a trial of spinal cord stimulation using high frequency, and then that group would be implanted. Then both groups would be followed up with allowance of crossover at 6 months, period. What is unique about at least our site here in New Orleans when we started that trial is that we made a decision that if we're really trying to look at a medical device, and we're comparing here a disease that had been treated for a long time utilizing medical management using pharmacological therapy, is that we bring one of our co-investigators who was a world-renowned endocrinologist that particularly have interest in diabetic neuropathy. And we decided that that particular neurologist would be our screening person, and he would be the person completely in control of the medical management arm. He has no idea about spinal cord stimulator, with the exception of us explaining the indication for such a therapy and just indication how some of the mechanism of action of that technology worked. So Dr. Waifu, who was our endocrinologist taking care of that medical group, he took care of that medical group for the whole 12 months. One of the major things that we also utilized in our site was a diabetic registry that was built or designed way before we started that study, that had about maybe 500,000 diabetic patients over 3 states that Ochsner was able to gather. And what was unique about that diabetic registry is that we were able to use Watson artificial intelligence to look at the charts to help us actually recruit for those patients. So I think our site for this study have utilized a lot of innovation to come up with those good results that I'm going to explain. So looking at the demographics, and you can see here, the demographics of both group was very similar. Type of diabetes, you can see the type 2 prevail in that study. You can see the duration of diabetes and the duration of painful diabetic neuropathy was comparably, longevity of that duration is really evident in that trial. You can see those patient has been suffering from that chronic condition for quite some time. And those patients were either randomized to the medical group or the spinal cord stimulator in the medical group and allowed to cross over at 6 months. So the main endpoints at 3 months was just to compare both groups to determine efficacy, with dropping more than 50% of the pain from baseline without any worsening neurological manifestation that was not already present, and to study the safety of utilizing such a medical device in that population patient. You can see here the results of 6 months, and those results were discussed by the PI, Dr. Patterson, back in NANS in January. And you can see the comparison between the medical group and the medical group plus the spinal cord stimulator group, very significant reduction in average pain score, as you can see in the research group. Now you can see also here, these tornado charts, one of the charts that I like, because kind of like represent every patient in that trial, and you can see, the average pain relief and the drop from baseline. Also, remitter was defined in this study as pain VAS score less or equivalent to 3 for 6 consecutive months. So you can see here, there's quite a high percent of remitter in that study in the PDN spinal cord stimulator group, about 60%, and that was statistically significant. Also, through the 6 months of that study, and hopefully in the future you're going to see a lot of subset out of that, we were assessing neurological manifestation. We had multiple ways of assessing those, but the majority of the discussion here in the study would be going back to like physical exam and utilizing some equipment, particularly recommended by neurologists, for looking at sensory exam in particular for those patients. And you would see a lot of data here that is a little bit subjective from the examiners of, actually improvement at 6 months of some of the neurological manifestation. We're hopeful in the future also would see more, objective measures of that can maybe even also explain why we're seeing such results. Discussing adverse event usually in that subset of population, if you've been doing spinal cord stimulator for some time, you would always think about, a lot of comorbidities. People already have diabetic neuropathy, had painful diabetic neuropathy was average of 5 to 7 years. So that population by definition is considered a kind of non-compliant population. What we've seen here is particularly infection and removal of spinal cord stimulator did not show any increase from average implantation out there of those devices for even patients who are non-diabetic, and we're still following this up to 12 months. So I'm going to shift gear a little bit from peripheral diabetic neuropathy, knowing how we utilize that data and how we actually compared those two groups only using high-frequency stimulation. I'm going to talk about another study done by Mark Russo in Australia. But before I go into that study, I wanted to just refresh our memories about multiple waveform and theoretical mechanism of action of those waveform, looking at low frequency and high frequency, and then also the idea of that we're seeing right now is what about paired waveforms, utilizing multiple different waveforms with multiple different frequencies in one set of patients. So what Mark Russo did in Australia is that he looked at like 17 clinics, 230 patients who already had high frequency stimulation, IPZ, who has been asking for additional optimization. So not particularly loss of efficacy at that time, but those patients were passed a very successful trial, had a successful implant, but they were looking at more optimization of the device. And the thought was, what happened if we try to increase the versatility of the waveforms and give them multiple different waveforms at the same time? Predominantly, back and leg pain, as you can see here, so leg pain was about 46%, back pain is 27%, and the waveform frequency that they decided to use is either frequency pairing or just using high frequency burst stimulation. If you notice here, that actually showed a lot of improvement following waveform pairing. You can see those in those tornado chart over there, about 57 responders rate compared to 34.8, and improved the function about 62% of the patient, with reduction of pain medication about 33% of those patients. So while it's particularly not a huge, big randomized controlled trial, but I think that start from Dr. Russo over there can give us an idea that utilization of wave pairing or versatility of waveform might be something helpful also to optimize our patient, if not actually to salvage some of what we think about as failed patient after neuromodulation implant. I know Dr. Capral represented the rescue trial. And now we might have other options instead of actually explanting and trying to reimplant devices. It's thinking about all those devices that can do multiple waveforms. I always think about, when I know that was asked at the previous panel, what's your algorithm for a patient coming to you with back pain, leg pain? Are they suffering from neuropathic pain, CRPS? And, each pain physician, I think, build an algorithm for their head. I really like the answer about discussing that with the patient and making the patient part of the treatment. But always in my mind, I want this imaginary device that can be able to do everything. All kind of waveform, all kind of leads covering, every single portion of the spine that I think needed to be covered to cover, multiple variety of painful pathologies. And I think we're very close to that. And, one day we might be looking at, one device that's causing, doing all those majorities of waveforms. I also wanted to mention, the second question usually comes to my head is that we're presenting a lot of great RCTs, and, you're taking a subset of patients and they're really subjected in a controlled environment to have that particular research, and then you're coming up with those wonderful results. But then we apply that in real world and kind of get a little bit disappointed if that's not the case. And I was just mentioning here one publication that came out regarding high frequency stimulation that showed, real world evidence compared to a randomized controlled trial that ran by Dr. Capral with the Senza RCT, and showing that done in a lot of patients has kind of gave us a very comparable results of pain relief. Leave the discussion back again. I talked about the registry that we had for diabetic neuropathy that utilized artificial intelligence to help us recruit for the PDN trial. And I'm thinking that these big registries right now should move to our field, should move to pain management field. In the previous panel, we discussed a lot about, registries that even can show you the x-rays of the patient, remind you where the leads were, what kind of waveforms tried, what kind of pattern, where exactly that we tried those leads, what we considered a sweet spot versus other levels that we tried those. And I think building those clouds is very important to all companies, not particularly to one company. And we have to all agree that we all need this data for our patient. It's helpful for us. It's helpful for us to understand, the progress and improvement. And it's helpful for our payers to understand that, these neuromodulation devices really help and really work. And it's worth paying for. And with this, I end the slides, and thank you.